my name is Augustine Colebrook. I'm the principal at Midwifery Wisdom Collective. My focus is on big picture political movements that are happening within the profession, some of the controversial questions, and centering voices that are not being regularly heard.
I'm Layla Wyatt. I am a traveling student midwife, learning midwifery from cultures and a lineage of midwifery throughout the United States. I'm here to center the voices of students to hear their calling, their pathway, why they chose midwifery, and even share a bunch of birth stories along the way.
Greetings, I'm Jamara Amani. I am a midwife, a mom, and a social justice activist. I am here to challenge white supremacy, homophobia, transphobia, and anything that keeps people from being their best and living their best selves, as we have the human right to do. And I am looking forward to sharing stories of birth justice on this podcast.
Hi there, I'm Delmar Bowden. I am non-binary, queer, transgender, Latinx, midwife, and full-spectrum doula. My focus is on increasing access and equity in midwifery care and midwifery education.
Hello, my name is Angie Love. I am a community nurse midwife in Vero Beach, Florida at the practice of Midwife Love. I also do telehealth midwifery through Midwife RX. I'm a mama, and I am committed to maintaining birth choices for all people and educating a future generation of midwives because we will not die out.
Welcome to the Midwifery Wisdom podcast, and I'm hoping we can do like a little intro. Like some people really know who you are and like how incredibly cool you are, but a lot of people don't. So will you give yourself an intro?
I have to I don't, what do I say? I mean,
Midwife extraordinaire.
see, I wouldn't say that.
I would say that.
Yeah, you can say that. I would just say I'm just me.
Well, just you is a midwife of 30-ish years.
33 this year. It's 33 years.
Yeah. Who has worked internationally for many of those years.
Yes.
And who has attended some thousands of births. Do you have a number?
Yeah. I don't remember the exact number now because I just retallied. And I still have a little jet lag. It's over 5,000 at this point. I just did. So in the last 6 months, I just did 300 and something. So.
And those are in either home birth center or low resource settings, correct?
Yeah.
Like like all of them, right?
Yeah.
So I think I would be hard pressed to find another CPM alive today who's attended more than 5,000 births.
Maybe. Maybe I don't know. My friend Cynthia, she's attended quite. I'll ask her how many, but because I know she keeps track, and she's practiced 10 years longer than me, so she may have. She may have.
But it would be hard to find. So hence my title, Midwife Extraordinaire. That's my point.
Okay.
Okay. And then during this time, you have got to become kind of by necessity, I think, and also by passion, an expert in twins and breeches.
Yeah, out of necessity, I guess. That's correct. Yeah.
Do you have numbers on those figures?
Again, not exactly. It's in the 300s with the twins, and there have been a few sets of triplets as well. And then with the breeches, it's 511, I think, or 14. Again, I should remember, but my brain is still not quite in this time zone, but right
it's
around
still
that.
A lot of numbers to keep track of. So
Yeah. Mm-hmm.
Yeah. So aside from traveling with Doctors Without Borders, Médecins San Frontières, you also teach with teach Breech and Breech Without Borders, right?
Yeah. I'll be doing some of the simulation workshops here coming up in April that aren't too far from me, some in Minnesota and some in Illinois. And then, we'll just see beyond that. Yeah.
And you can find out more information about that. We'll link those courses below. And you're also coming to play with us in Texas in November.
I'm so excited. Yes.
I'm so excited too. Yeah. At the Midwifery Wisdom Experience, Kristine is going to be a mentor in skills, and she's also going to give a presentation. And you've entitled your presentation Humanitarian. Tell me again, what is your title?
Humanitarian aid from a midwifery perspective, or midwifery from a humanitarian aid perspective. I guess it can work either way. But basically talking about those aspects of the work.
That intersectionality between the midwifery model of care, and yet in places that are needing extreme support. That's so amazing. And of course, this presentation I think is going to be particularly epic because of all your stories and photos, and like people are going to get to take this whole journey with you. I'm so excited.
Yeah, I hope so. I'm really excited to do it and put it together, and I'm looking forward to it.
Well, today's conversation, I really wanted to be about you and your experience and the wisdom that you bring. This is the Midwifery Wisdom podcast, and so we are trying to share all of this wisdom, and you carry a particularly large chunk of it, given all of your experience. I'd like to talk a little bit about some of the births you've just recently attended, but I'd also like to talk about American midwifery and what works and what doesn't. And because you have this global perspective, I feel like you could shed some light on what we're doing and what we're not doing well. So first of all, tell us, what was the most challenging birth you've attended in the last few months, and where have you been?
Oh, man. I just got back from South Sudan. I was there for 6 months. I was in a refugee camp that had about 130,000 people, and I was working in a referral hospital. And when I say hospital, it's more like, it's not a building, it's in the camp. So it's more like a MASH unit, if you could imagine that. It's a lot like that, including the helicopters flying, overhead, because we were pretty near an airstrip. And so, we're in this environment, and we basically are serving for the maternity portion of the hospital. We serve the different clinics that we serve as a referral for them. So they attend all of the lower risk and just women walking in having babies. When it gets complicated, or when the women are more high risk, then they refer them to us. So that's basically what we're doing. So if somebody's bleeding, if somebody has twins or breech or anything that polyhydramnios, we see all of those things. And that's basically what we're doing most of the time. So it's all high risk. Not that, the women to begin with are just high risk, even when they have normal pregnancies, just by virtue of the context that we're in. But it puts it to a whole new level when they have issues during the pregnancy. So that's what we see, our referrals from our other projects too.
And some of those women get flown in, not just nearby.
From two of our other projects, they get flown in, and not in any kind of timely way. We only have flights a few times a week. So it's not like if somebody is a few hours away by air and they have an obstructed labor, the midwife in that project can go, well, let's fly them into Bentu and Kristine will take care of them. It's not like that. They will get the flight out on the Tuesday or Friday. It's not a right away sort of thing. So it sounds great to be able to fly somebody there, but it's only gets done with a lot of planning. There are no emergency. Nobody gets flown out emergently.
Right. So they get identified, like they've got bleeding during pregnancy, they get sent over, their baby's in a funky position. There's 2 babies, they're dealing with preeclampsia, they need a reason for induction, something like that, right?
Yes.
One of the interesting things that you and I have discussed, I think, that always makes American midwives have pause, or even any Western midwife, is the way that care is prioritized in these kinds of environments where there are scarcity of resources. And one way is that they generally don't make clinical care decisions to quote unquote save the baby. Can you tell us more about that?
Sure. Yeah, it's the same pretty much in most of the places that I work. The care centers around the woman, the mother, and it puts her needs, her life first always. And that's just basically because usually there are other children involved, and without the woman there to care for the other children, there is those children are left as orphans, and their survivability is very low. So yeah, we always prioritize the woman's life, just for.
And it sounds obvious, but actually when you start to tease that apart into the how, that means that you don't do cesareans for babies in distress. And I think that's what's really shocking to Westernized folks, as you know, obstetrics around the globe has sort of marched towards this 0 death rate that they somehow have as a goal. They have done all manner of interventions on the birthing body to save a baby. And that's just not something that happens in low resource environments. And I think that's really shocking. So tell me what that's like, because I mean, people practicing in high resource areas, you know, you hear heart tones that aren't reassuring and you're immediately rushing for help. How does that feel when you experience that?
Yeah, it's you know, I know what our protocols are, and because of that, I've learned to know that this is how it is. This is what we have to do. And even though, even in this particular project, I recognized fetal distress a few times, and it was very obvious that the baby was in distress and would not survive.
Bradycardic or decels or something.
Yeah, see, I heard, you know, oh, the fetal heart tones are 60. Okay, well, and she was 4 or 5 centimeters. It's like, well, there's nothing we can do. If they're like 9, if they're getting close to the end, and then we can maybe try to push it and get the baby out, do our best to get the baby out in as quickly as we can, and hopefully save the baby. But otherwise, because we could use vacuum or something if it's down low enough. But otherwise, no. There were times when I knew a baby was not going to survive, and there was nothing we could do. And that's just how it had to be, because once you do a cesarean for on a woman, especially, and I remember specifically one of these women, it was a first-time mother. She was 17 years old. As soon as we do a cesarean on her for fetal distress, that her all of her childbearing years are now, we cannot guarantee that she will have access then to any kind of surgery in the future. It puts her at much greater risk for subsequent pregnancies. And she's got 2 decades of childbearing, and they have many, 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 many children. So every pregnancy, every subsequent pregnancy for her and for the subsequent babies are all much higher risk. And so, yeah, we do our best to not leave women with scars that they then have to deal with in a year or two when they get pregnant again, because we guarantee their access to surgical intervention.
Yeah, and I think it's just, I don't know, the stark contrast between where the Western world has gone and where you have to go is really fascinating to me. Well, tell us one of the most memorable births that you attended in the last couple of months.
Oh wow. There were quite a few. I guess my my most favorite one was a woman that came in with P-prom, and she was about 32 weeks, and we put her on the ward. But then, and this was back in December, and I think, and she started coughing, and I was always on high alert for any coughers. I'm like, is she coughing? I would say to the staff, I'm like, get her out of here. We always had to, anybody that was coughing, we had to refer to COVID isolation. They needed to be tested. They stayed there until the test was complete, and then they got sent back when they tested negative. But she tested positive. So that meant that I now had a patient in COVID isolation. And so what happens then is I have to completely suit up in complete PPE whenever I wanted to see her, which was, I checked on her several times a day, and it's like 104 degrees. And I'm like, it was just awful with all of this PPE. Anyway, I had to rally the water and sanitation team to get an area in COVID isolation where I could actually attend a birth, because with P-prom, I knew she was going to, she would go into labor fairly soon. And she was already on antibiotics and stuff, and on dexamethasone for the baby. So they rallied and got this little birthing hut, and even had, running a cold running water sink, which was great. And I got all the stuff ready, and just told any of the COVID people, if you notice, if she says she's in labor or whatever, just call me right away. But I was going about every 6 hours to listen to the baby and check on her. Great. So she finally goes into labor, and I think it was the next day. And I was ready, and I in all my PPE and sitting next to her. I don't have any of my staff with me, so I can't communicate with her because we don't speak the same language. But it was her 5th pregnancy, and I'm like, but it's okay. It's like, I don't need any words. I'm just gonna watch her labor, and I'll know. And it was fine. It worked out perfectly fine. Just to sit there, and I could see things ramping up. You could just tell she looked more uncomfortable, and she was lying in bed the whole time. The baby was breech, and I knew this. It was not, regular 32-week size baby. So I was expecting it to be at least maybe about 1.5 kilos. So anyway, so she was laboring, and she was in bed the whole time because, of course, she was sick with COVID. So she was not feeling well. And as she labors, I'm sitting by the bed sweating in all of my PPE, but I'm all prepared. And then finally she's lying down, and she has her knees up, but then she just starts to part her legs a little bit. And I'm like, okay, here we go. This is going to happen. And I really wish I had videotape of this. I'm watching, and I can see something start to peek out, and I'm like, okay, good. And I see like little digity things, and I'm like, okay, some toes. And then, but they got longer and longer. I'm like, and so it was this hand coming out, and like my head, the cognitive dissonance that this created in my brain, because I'm like, I know that this baby is breech, right? And there's no way in front of me like that it could have turned to transverse, like I'm looking at her belly even, but all of this is happening in my brain in like a matter of seconds. Like it doesn't look transverse. I got to get that back up. So of course I can't speak her language. So I'm like, okay, I'm just going to like tuck this back up in there. Cause what I wanted to do was tuck the hand up and then go up and see what I could feel and just kind of reposition. I'm like, okay, this is a tiny baby. I'm just going to reposition it because, you know, I'll get it out. No problem. I wasn't worried. I was just like, more like I was embarrassed and glad nobody was there. Cause I'm like, when did this baby turn? Cause I'm expecting this breech baby. So I'm pushing it in. She's pulling my hand away. I'm like, no, honey, I got to get it back. And in the meantime, she keeps pushing. And then the hand comes out further into the wrist. And then something else is coming with it. And I'm like, okay, well, whatever's coming is coming. And I took my hands away. And it was breech. It was a little butt cheek that came, and then the rest of the butt. And then the whole baby just came out. But the baby had its hand behind its back. And it was it was just a compound presentation with the hand and the butt. I have never seen anything like it in my life. And I was just cracking up inside. I was also relieved that, oh yeah, okay, the baby is breech. It just was also with the little hand. And I hadn't done any vaginal exams. There was no reason to do them. And if I had, I probably would have felt the hand, but there was just, I didn't. So it was a complete surprise. And I've asked several experienced midwives that I know, and none of them have ever had a hand presentation like that with a breech. So I was just delighted. And I think that delighted me for like several days.
33 years and you can still see something new, right? That's so great.
Yes. Yeah.
I love that.
Still surprise you. Yeah.
So he was just kind of grabbing onto his bum, huh? So his hand came out on top of the bum.
It was like turned. He had it like backwards and up. Like, and I'm like, how uncomfortable. Like, who gets born like that with their arm behind their back?
Maybe that hand is what actually broke the water early, trying to get his hand out or something. Oh, how fascinating. Maybe her coughing broke her water. Who knows? Well, what a story. And everything turned out okay. And even though he was early, he had no breathing issues or anything. Right?
No, none at all. I think the dexamethasone, we got, I think, at least 2 rounds of that in. So, yeah, he did really well. No issues at all.
That's amazing. That's amazing. What a great story.
COVID. So,
oh, good. Good. Yeah. Well, Kristine, something that I think listeners will be struck by is how broad your scope is. It does not match the typical American midwifery scope. How did you add this much extra knowledge? Did it come from the trainings with Médecins San Frontières? Did it come from experience out of the country with other organizations? Did you just do a lot of self-study? Did you pick it up along the way? How did you expand your scope so tremendously? Because I mean, like, let me just give context. When you and I talk on the phone, you are sometimes the highest level provider in the camp, in the high risk center. So how did that happen?
Yeah, I usually am. Actually, we don't have obstetricians or even gynecologists, anything like that. There are MDs, they work in other departments, but they're terrified of coming into maternity. Like, that's the last thing that they want to do. And I know if I have a medical question, if I have something complicated by a pregnancy that is also complicated medically, maybe the woman has pyelonephritis or whatever, I'll sometimes consult one of the MDs and go, yeah, help me. What antibiotics do you want to give her? And how I'll co-manage it with them. But otherwise, yeah, most everything it's been on the job and studying, self-study. MSF doesn't give you any specific training per se. We get a lot of support. We have telemedicine. I can call one of the referents or email a referent if I have things I want to, case I want to discuss. But otherwise, it's just been learning, trial and error, and whatever comes in. You never know what's going to walk in the door. and it's just stuff that that you never anticipated ever having to deal with, and then there it is, and you have to figure out how to do it with the limited resources that you have. So that's
Yeah, but like
basically
even the story you were just saying, like you're talking about steroids for the baby's lungs, and you're talking about antibiotics to treat this, and you're talking about treating full COVID patients on your own. Like how did that happen for you? I mean, I think some midwives who would like to join Médecins San Frontières would be overwhelmed because of the increased scope. How did that happen for you?
Yeah. Well, so I have worked out of the country, other places, and less, a little bit less complicated contexts. I mean, the contexts were still low resource, but so I learned a little bit as I went there. I worked with another organization when I went to Afghanistan. And I learned quite a bit. We handled about 700 births a month, and in that maternity. And so you got to experience a lot of things very rapidly. There were certainly plenty of just normal births. Women just come in and push out their babies and everything's great. And then there were ones that were way more complicated and just things happening all the time. I think during that time, I managed 10 cord prolapses during the time I was there. And we didn't lose any of the babies. So it was, that I learned a lot in Afghanistan, but that's because the volume was so high. And then I had other people, it was not with MSF. So there were physicians there that I was able to learn from that had been in the field for quite a long time. And then moving on to MSF, we have very specific guidelines. And so how to, if I want to learn how to manage a preterm birth, somebody comes in at 32 weeks, what do I do? If I don't know, I can turn to the guideline book. There's also an app on the phone, same guidelines, and it'll say 32 weeks you give, and then dexamethasone and this amount, this many hours, and all of those medications are provided. We have all of them, usually, unless there's a problem with supply chain, which also does happen, and then you have to use something else or you have to go without. But it's basically, I follow the guidelines, and a lot of the things that walk through the door are not in the guidelines because they're just really out of the box. It's several things mixed up into one. So yeah, it's really just trial and error.
We talked on the phone a couple of weeks ago when you were still there. And I can't remember the case, but you had some case where you said you were like rushing and like helping the local midwives and like doing the best you could, and kept looking over your shoulder, hoping that like the next most experienced person would walk in, and then realized it was you. I loved that story so much. And I wonder, like, has that happened to you? Does it happen to you regularly?
No, not anymore. So I had that thought I was in Bangladesh, and I remember dealing with it. It was I remember specifically the case. I had walked into maternity in the morning, and they were managing a breech, and it was preterm. I'm not sure exactly, maybe about 34 weeks or so. So I walked in the middle of it, and the woman's already pushing the baby out. And there was a cervical head entrapment. And so, that's every, if you ask midwives here, about breech, that's their like worst nightmare is, what about if the head gets stuck? And so, this is what I walked in on. And so I have to figure out, of course, I don't know that this is what it is. I have to figure it out by like going in and using my hands and feeling around and going, okay, so we have this small baby. I wasn't here. I don't know how dilated she is, but it feels like she was probably dilated about 7 when the baby started to come based on what I was feeling inside. So I have to work to get this baby's head out. And I remember, like going in there and, getting my fingers up and in and trying to kind of like do like MSV to kind of get the baby's head tilted and bring it down. But, it's like this really tight reverse turtleneck. And yeah, at one point in time, I remember looking over my shoulder, and I'm like, I was looking for someone to help me, like somebody that knew more than me that could get me out of this situation. And I'm like, nope, it's just you. And when that kicked in, I'm just like, okay, well, I have to get this baby out. This is not sustainable for this woman to have this baby hanging out of her body. And failure is not an option. And so I just had to keep working at it until I got the baby out. And I did. And I have done that a few times since, the same sort of scenario. So I have been there. I have lived the any worst nightmare that a midwife can think up in her head. I have probably lived that nightmare for real.
Yeah.
So
yeah.
And
how do you deal with that? I mean, I know that these missions are incredibly taxing, partly just because of the sheer devastation and heartache in these war-torn or refugee camps. Also partly because of just the low resources and the environmental stress on your body. It's either very cold or very hot. You're living in tents or without a lot of resources yourself. That's all would take its toll. But then there's this other piece that I think so few midwives ever really tackle. When you're working so remote or with so low resources, the buck does stop with you. Failure is not an option. And that's a kind of heavy responsibility, a kind of weight that a lot of people can't even imagine. How do you cope with that?
Yeah, that's a good question. I guess I understand what I'm capable of, what I understand the resources that I have. I understand the guidelines that I have to follow. And I know that I can't save everybody, even though I want to. I think it's human nature, but I know that I can't. The deaths of babies are a little bit easier to deal with because they happen so frequent. Like I deal with in this mission, I think almost every day there was a death whether it was just a miscarriage death or a 18-week baby, or it wasn't that everybody was coming in having all these stillbirths, but there was death almost every day. There were little tiny fetuses of any given sort most of the time. So after a while you get a little bit more accustomed to that. It doesn't mean that it's not sad, especially with the first time mom losing her baby. That's always really difficult. But for me, I think the maternal deaths are the most difficult. And I on this particular assignment, there were usually there's in a context like South Sudan, you can expect in a 6 to 9 month assignment maybe one, and sometimes none. But in this one, there were 5 in a short period of time, actually, and none of them were preventable. They were all one was from COVID complicated by HIV and malaria, and the other 4 were from hepatitis E, and the death rate for pregnant women in 2nd and 3rd trimester from hepatitis E is very high. And these women were already very sick by the time they walked through the door, and there was nothing that could be done for them. But it's still quite a burden to watch somebody die like that, even if they weren't pregnant. and it's still considered a maternal death. So those were difficult. And I guess the way I looked at it was that that these deaths weren't preventable by the time they walked in through the door of my maternity, but they could have been preventable prior if they had gotten a vaccine there earlier. Back in October, we were supposed to start a vaccine campaign for hepatitis E, and then there was this terrible flooding that happened. And so we're in the middle of a refugee camp, in the middle of already what is a humanitarian emergency, and then there's an emergency on top of the emergency. So the flooding was catastrophic, and we ended up with an influx of like 30,000 more people in the camp that we're caring for. And so this delayed the vaccine. And if the vaccine campaign had happened, these deaths certainly could have been preventable. So in that way, it was hard. But I guess I left the assignment knowing that there were no deaths on my watch from the usual suspects, which are hemorrhage, infection, hypertension, eclampsia, and unsafe abortion. None. So I felt like I did my job in that regard. And so that's what I do. I try to I look for the positive spin on things, because there was nothing I could have done for any of the 5 women that died.
Yeah.
Absolutely nothing. There would have been nothing that they could have done if they were here in the United States. Nothing.
Right.
Nothing.
Right.
So,
Right. And in some way that can bring you some solace, but it doesn't take away the pain of witnessing those families grieve and the person suffer, for sure. Yeah. Well, I wonder if you can tell us, I mean, I know that it's really challenging work, but it must be so fulfilling in many ways. And I wonder if if people listening had the idea, like, wait, I want to go work for humanitarian aid situations. We see the crisis happening in Ukraine right now. And, around the world, there are many actual environmental crises happening where people need help. And what would you tell someone who is applying? What should they know? What's amazing about this work?
oh, there's so much that's amazing. I love it. It's really challenging. It challenges me, and it pushes you to your limits. You figure out what your limits are, and where you need to improve, and in all aspects of yourself, not just clinically, but in every other way as well. It feels really great to help somebody that really, that if you hadn't physically been there at that time, that this person may not have survived. It's nice to resuscitate babies and be able to hand them crying to their mothers who, their last pregnancy, they lost the baby. And I mean, there are a lot of moments that are really very just triumphant, basically. And it does make me feel really good to be able to help in that way. The just hemorrhages and things that are difficult to manage. I mean, I managed one eclampsia, and one eclamptic patient. She had 7 seizures. It's my record now. 7 seizures in a short period of time, like, I don't know, in less than a 2-hour time span, 7 seizures. So, and just getting somebody through something like that, and then coming out with a live baby and a live mother, and watching them walk out of the maternity a few days later, both healthy and fine, like it gives you a sense of accomplishment. It's like, okay, great. We did a good job. We managed this. Everybody's alive. This is great.
Wow. Wow.
So, I mean, I guess those are the things that, because there are a lot of good, positive things that come out of all the challenges.
And you work with an international team because volunteers from MSF come from everywhere.
Yeah.
That must be interesting.
Well, we have a national staff. The national staff that I manage, they're all South Sudanese. And then the other expats that are there, they're from all other countries, and they do all the other profiles. There's not a lot of intersection with maternity because maternity is so highly specialized. But like I said, once in a while, I call in one of the MDs to come and help with something that might have nothing at all to do with maternity, and I'm handling the maternity aspect. We move the patient, like the COVID patient. I co-manage that with the medical staff. They manage the COVID aspects of it, and then I manage the pregnancy aspect. And then if there's an intersection, if we need to discuss, like, okay, should we induce this woman? Should we be giving dexamethasone, because will the baby be viable if she happens to expel? Those kinds of things. We have these discussions, and then we decide together the pros and cons. And we have certain loose guidelines in these regards, but a lot of it is judgment, and a lot of it is kind of ethically what is the better thing to do in the situation. So yeah, I work with the other team.
To wrap up the MSF chat, what are their qualifications that are required to join MSF? They have to be a CNM or a CPM.
Yeah, or a CM. Yeah, and yes, specifically for midwives, you have to have prior out of country experience, not necessarily in a medical, like if you were in the Peace Corps for 2 years, 10 years ago, and then you came home and you became a midwife, that's fine for them. They just want to know that they send you someplace really hot and miserable with spiders and snakes, you're not going to freak out. Mm-hmm. So you don't have to have given medical care per se. But that certainly helps. They like you to have language skills, specifically French, because a lot of the countries where we have projects are French-speaking countries. And you have to be at least 2 years out from like you can't have just graduated. They want you at least 2 years working independently, or in a hospital. So, but that's basically it. It's all on their website. They list very specifically what they require, and they don't add to their pool a lot. And again, it's not that you're hired by them, it's more that you're brought on and you're put in the pool. And then if they have something that matches you, this is in the beginning, it matches and you're able to dedicate. Usually it's not, a first assignment is usually 9 months. And no, you can't bring your family, and you can't bring your pug in case you have a pug.
You asked, didn't you? I know you asked.
Like, I would go longer if you would let me bring my pug.
That's fantastic. I love it.
But yeah, so you can't bring your family, and they don't have, just a few week assignments or very short term. They don't. They're long. Because they want the continuity of somebody there. So it does not work well for somebody with family and small children. It's better if it's either before you have your family or it's after your kids are up and out.
Yeah, that's smart.
Yeah.
Well, so I'd love to ask you to reflect on these years of experience, this really expanded scope that you have the different perspective that you have dealing in these environments, and really kind of look at the US and the failings of the maternity care system in the US. What have you learned or experienced that you wish could come back home with you to the systems in the US?
Oh, wow. It's just so much. There's just so much that's broken here. I guess, I mean, if we're looking at the hospital system, just the lack of respect for women and the and birthing people in general, and autonomy and informed choice. And I mean, it's basically non-existent here. I mean, I can't go, people talk about like the trauma that I experienced, vicarious trauma, going to these places. I would take that any day to walking into an American hospital and supporting somebody birthing in a hospital in general, anywhere in the US.
Walk us why. Tell us specifically why. Why?
I find it very traumatizing, just the way the obstetric trauma and abuse. Women are just not treated as though they can make decisions for themselves or their babies or their bodies, and they're just not respected. And as soon as a person goes into labor and they walk into the hospital, it's like their power has all been given over to all of these people that supposedly know better. And I just watching just a vaginal exam being done, instead of asking for consent, they say, okay, this is what I'm going to do now. And then before there's even any yes or no or okay, they're shoving a hand in. And if a woman doesn't have an epidural, I think, and doctors forget, like, that if a woman a person doesn't have an epidural, you have to be a lot more gentle. I mean, I think you should be gentle anyway, even if they do have an epidural. But I watch these exams and it's like these women, they're jumping off of the table. And I'm like, what are you doing? Why are you being so rough? I've been doing this for 33 years. You don't have to do that. There's a way that you can do an exam that doesn't cause somebody to react the way, like, it's like, what kind of information are you getting that you have to be this rough? There's just stuff like that. It absolutely freaks me out, because I watch how the person then responds, and it's just, you can see it's very traumatizing for them. And there's just no reason it needs to be that way. And it's just something, and that's just a really small, simple example. Like, things like that, I just can't take it. And then if I'm there and I'm supporting somebody, that the staff, they can throw us out at any point in time. We don't have the right to be there. They can throw us out. So to say something like, whoa, hey, what the heck are you doing? Why are you doing that? They don't have to put up with me being there and questioning them or asking why they're doing it. So then I can't be there anymore to support that person. And then I've just literally cut off any kind of support that she has if I go and intervene in that kind of way. And then they make me leave. So again, I feel complicit, like I'm part of the problem if I don't say something. But then if I do say something, I could get thrown out. So I can't go.
It's the powerlessness, right? From the mother and from the people attending. Yeah.
For everybody. Yes. It's an awful feeling. So I feel very bad for anybody that has to support birthing people in environments like this.
I feel like doulas are so vitally important. And at the same time, oh my God, like, to be a doula in hospitals in the United States is, I think, one of the most vicariously traumatic experiences I could possibly imagine.
Yes, I agree.
If you believe in autonomy and sovereign decision-making over your own bodies, I think obviously that's a prerequisite. Yeah, it can be so intense. Well, so thinking about all the things that you learned, what are you surprised when you go to conferences or hear people discuss online? What are you surprised that American midwives don't know that you feel like is like a central part to your education and your knowledge? Clinical or otherwise?
That's a good question. I guess it depends. It depends on, I mean, I'm always surprised at the varying degrees of education that CPMs specifically have. It seems like there's a wide variety of knowledge. Some are very very savvy when it comes to more clinical and like technical aspects in terms of like lab work and testing, and they're very savvy in that regard. And then there are others that they don't really order labs, or they're not used to interpreting lab work and just things like that. That's just one sort of example. So I'm always really surprised at just the different levels of I know it's supposed to be kind of standard because, you know, there's the PEP process and you have all these things, these checklists, but still I think it's a huge, there's a huge range of knowledge when somebody actually gets their, you know, tests and gets their CPM between different midwives. When I talk to some, just the degree of what they do and do not know. And I'm not saying this in a critical way. I'm just always really, really shocked because it's not
Uniform.
Yeah, it's not uniform.
It's not a uniform process. And at the same time, we have this widely varying competence in definitely in clinical skills across the nation.
Yes.
We
Yes.
also have kind of an epidemic of people who are in fact failing the exam.
Yes.
2 and 3, and you know, I'm consulting with someone who's failed it 7 times.
Yeah.
And certainly some small percentage of that could be people who are not prepared, but most of the people that I hear that fail the exam are actually already have been practicing or have been in the birth world for 7, 10, 15 years, that kind of thing.
Yeah.
Or trained under some of the nation's most respected midwives, or graduated from one of the most respected, schools. And there's this real disconnect between what the educational certification process is, the exam, and what is actually happening in place. Why do you think that is? Do you have any theories about why that is?
In terms of the exam
or why there's such widely varying range of capacity, skill, and knowledge? I mean, what's so different?
Oh, I think some of it is there's the self-study apprenticeship model that I think it's still alive and well out there. And then there are the other midwives that go through like a MEEC accredited program where maybe there is a lot more academic things that they're learning. And I think those programs also tend to teach to the test. For me personally, when I took the test, I don't know what it's like now, but back in a few decades ago when I took the test, it didn't seem to me like, and this is just my own personal opinion, like there wasn't anything on the test that I felt like would make me a good midwife or a better, like if I didn't know something like that. That piece of knowledge was, the test just didn't, it's not what I would have tested. They're not the questions I would have asked. I don't know. And I scored okay on it. I passed it.
Yeah.
But I just felt like that it didn't make sense to me in terms of if you really test somebody for going out there in the real world.
Competence.
Like, that's really what you want them to know? Because
I had the same experience several decades ago. And I remember thinking, this 8-hour exam is the sum total of what they think I need to know. There's not even a single test on labs, ultrasounds, blood work, IVs. There's not even a single question in the test about any of that. That was really confusing to me. I think I came in with the idea that the NARM is an entry level exam for if it's the common denominator, right, then it has to play to the lowest common denominator, because that's who would test and pass, right? And so I think because the nation has evolved so differently in the different regions, it's a test that is qualifying folks who practice in states that don't have a legal process, that don't have access to labs or ultrasounds, that don't have consistent backup, that aren't allowed to carry meds. And so it's a test that caters to that. Whereas, Washington State, for example, not only gets full Medicaid reimbursement at proper rates, but also now is able to carry all manner of medications legally. And I think the range is evidenced by how the different regions of the country have evolved differently. And of course, the bridge certificate was trying to bridge that gap. But I'm not sure it's done that effectively. And of course, the NARM PEP process still is below the ICM standards, the International Confederation of Midwives Standards of Education. And I think that is evident. And you and I both felt that. And I think that is evident in the process.
Yeah.
What's the solution? Like, if you could, without any detractors or critics talking to you, and if you could just imagine, Kristine has a magic wand and she's going to wave her magic wand and bring the US into the modern age, saving lives without causing undue harm. How do we get there? Like, how does this work? What are some initial steps that advocates, policymakers, folks that might not even be midwives take to bring the US out of the crisis that it's in? Which, if people don't know, we have almost the highest cesarean rate in the developed world. We lose the most babies, we lose the most moms, we have the most unnecessary cesareans. 50% of the counties in the United States have no maternity health care at all. People sometimes have to drive 50 and 100 miles to access care, et cetera, et cetera. I mean, we're in a real crisis. So how do we get out of that?
Yeah, that's a great question. I think that we have to look at the ICM standards, almost treat ourselves as though we're a developing country. It's like, what are the standards for these places? And if we're not meeting that here in our own country, if we're not, if our cesarean rate is exceeding what the World Health Organization says is an acceptable rate, then we have to look at that. But I think, I don't know, it's the system is so broken. And yes, more midwives are a solution, but then you have to find a way to educate the midwives, and you have to find a way to integrate them, and find a way to for women to have access and to be able to be able to pay a midwife, because there's the whole thing of the people that want to have home births or out of hospital births, and then they can't afford it. And then it's like, but then the midwife can't charge $1,200. Like, that's what I was charging like a few decades ago. That's not sustainable. So, finding a way to make it sustainable. There are just no easy answers, but I think kind of having more a uniformity with at least, like the CNM that's uniform. It's just all CNMs graduate with basically the same knowledge, right? So it should be the same with the CPMs. And people are going to hate me for saying this, but it needs to be more rigorous. The CPM should be more rigorous. I mean, I remember when I was certified, they weren't even, do you remember back when they didn't even require NRP to have your CPM? And I'm like, what? And I complained for years. I'm like, it's not even required to have NRP. Like, how insane is that? And now, of course, it is, but it's like, okay. But it took them a while to like, that was just seems so basic to me. So there are so many things that I think could be remedied. Just I think that the CPM I think it needs a whole complete overhaul. It needs from the inside out, and that's one place to start if we wanted to start just from, I mean, forget the broken hospital system, but just from the midwifery standpoint, I think that, that needs to be overhauled.
And I completely agree. And also at the same time, there is a whole movement of birth keepers across the United States who attend a weekend training and start delivering babies. How do you feel about that?
Well, I think, I have a lot of mixed feelings about it. I think as long as, like, we have to hope that families are educating themselves on the different types of, like, what is a doula? What is a midwife? What is a birth keeper? What are all these?
But when the definition of midwife is so different, right? Like, how do they figure it out?
Exactly. And so it's very difficult, I think. And I think if you're going to put yourself out there, you have to do it. Hopefully everyone is doing it in an honest way. Like, this is what I am. This is what I know. This is what I do. I think sometimes families.
I think you're giving people too much credit.
Yeah, I know.
I don't think they do it that way.
I know. I think sometimes families who, like, so they can't afford the Mary CPM down the road who charges $4,000, but this birth keeper charges half that amount. And so that sounds good to this family who doesn't really understand what the limitations of this person might be, even though they're saying they've told them, and I'm just there and I don't touch anything, and I know they all have their own different rules about what they do and do not, but I still think it's this illusion of safety for the family.
Yeah.
And I think then that's where we see trouble, because they think that this person is there, and if something happens, we want them there just because if you were to ask them, well, why do you want this person
just in
there?
case?
Well,
just in case.
In case what? Because you have to be aware of what they do and don't know, what they have and don't have.
And oftentimes the birth keeper doesn't know, right? They don't know what they don't know, and so they can't even give clear, informed decision making.
No.
And so this is the slippery slope that I feel like I'm on, right? Because I actually did give birth unassisted. I did not bring anyone with me. And and yet, if there was, somebody with me, I would never want it to be construed that they were responsible for the outcome of my choices.
Right.
And also, I would not want the government or some kind of lawmaking body to dictate who and how and where and with whom I can have my baby, right? We want that total sovereignty. We want that autonomy of choice. Right. And yet we have situations like, I think there was just 3 fetal deaths in a row in a state with a prominent birth keeper population, which are perceived to be preventable deaths. And who gets to decide, right? Who gets to make the call? As we march towards licensure, we've just added Illinois of all places. New York is working on bringing back its licensure process, and all of this march towards getting all 50 states licensed is again asking that question: who gets to decide who's the gatekeeper of this knowledge, of this experience, and of ultimately of parents' decision making. And I think there's just really no easy answer. Yeah.
No.
And then, of course,
No.
like you said, the payer source, like who pays for all this, right? If it's still always the family paying for it, then I think, yeah, the government has no say in it. But at the same time, we are living in such wealth disparity that so many people can't afford care. Yeah, we've opened a hornet's nest, haven't we? No way to put it back. Oh.
So much there. Yeah, there's just so much. And I'm very, if you want to have an unassisted, I birthed unassisted at home. I mean, I'm very supportive of that. It's not that I'm not at all. I think you should be able to birth where and with whom that you want. But, I think also that you can have people that are misrepresenting themselves. And like I said, giving the illusion of safety to families that just don't know any better.
Yeah. Yeah. A big public education campaign is probably necessary. Well, we can only hope. Kristine, you're home now. You're going to do some gardening and play with your pug.
When the snow goes away.
Right, there's that.
We got 8 inches coming in tonight.
Oh my gosh,
but,
amazing.
Yeah. But no,
and do you know where
it.
you would go next and when? No plans. Don't even ask me.
I haven't even debriefed yet. I'll talk with my career manager later this week, but I was supposed to actually, instead of South Sudan, I was supposed to go to Ethiopia. And then some of our staff were killed there last summer. And so they pulled everybody out of Ethiopia, but we're going back into Ethiopia again. So maybe it'll be Ethiopia, but I don't know when, and no time soon. I really need to decompress after this 6 months. It was 24 hours a day on call the whole time, and I'm so exhausted. It'll take a while.
I can only imagine. You've got a comfy bed and you've got the companion of your adorable pup, so hopefully that will happen.
He's in his
jammies. Oh my gosh, he has pajamas. You are a dog mom for sure. Well, tell people they can follow along with your journeys. They can read your amazing blogs that you write and see some videos you post from in the field. If they follow you on Instagram, Facebook, what are some addresses? Where can they find you?
Oh yeah, at honeymother64 on Instagram, and my blog is Midwife Without Boundaries, and that's WordPress. But if you search Midwife Without Boundaries, it comes up.
Awesome. Yeah. And then you created a course for people that want to know more about this life.
I did.
And it's called The Traveling Midwife.
Yeah.
What to know before you go. And it's midwiferywisdom.com. So you can find that there.
Wisdom. That's right. And I have another course coming up, hopefully in May, no dates yet, with you guys. And that's on gestational trophoblastic disease. So that'll be a molar pregnancy. That'll be an AP course for any midwives that want to learn about the super fascinating. Saw a lot of that in South Sudan, which is what inspired us to do that. And I have some cool pictures. So yeah.
Awesome. I know a lot of midwives are interested in diving into these less common issues, which of course you've gotten so much experience in. So we're excited about this next course and the ones that come after. Kristine, thank you so much. I just adore you. You're one of my favorite midwife friends. And I'm just so, so glad that we have this connection and that you were able to share your wisdom with us today. And we can't wait to see you in November in Galveston.
Thank you. I can't wait to be there. I'm so excited. And thanks for having me. I'm so glad I have stable internet and I'm not in the middle of sitting under a mosquito net.
Glad you're not too.
Hoping that the internet doesn't fail.
Thank you.
You're welcome. Bye.